Welcome to the orthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice. Listeners, welcome back this week where we're joined again by Susan Ferrero, where we continue our discussion on medical legal consulting.
A little bit of question on discharge paperwork and follow-up, particularly in, say, an outpatient setting, right? So in the ER, patients get the medical printout automatically with the discharge instructions that I've typed in there specifically, and then the medical red flags of when to come back. In an outpatient setting, I don't exactly have that. And so have you seen any cases of orthopedic urgent care, say specifically, where they have a documented instruction to follow up, the patient kind of falls off to the community for insurance reasons, for what have you? Has that ever come back on that initial treating provider?
Orthopedic urgent cares are becoming more popular and, even just in regular urgent care, someone has a fracture, right? And they need to follow up and you give them the instructions to follow up with, Dr. Jones. And right, it was something I've encountered in practice a lot was when I worked in urgent care or even the ER was that they call the doctor's office and they don't take their insurance or the person doesn't have insurance. So then they just don't follow up. So now they have a fracture that maybe needed surgery within a few days or at least something, or it hasn't healed properly and they have no follow-up. So in an example like that, I would say, okay, here you're going to follow up with Dr. Jones. If for some reason, because it will come back to you, you were the last person that saw them. And it can be said, okay, well, the instructions weren't good enough. You just told them to follow up with Dr. Jones, and the patient says, "Well, I couldn't, I didn't know what else to do, so I just figured it wasn't important." And I have a little bit of a problem sometimes with people need to take full responsibility for themselves and be able to say, "Okay, well, what should I do? What's the next?" And just leaving my cast on for 6 months is not the right thing to do, or taking my splint off and just winging it is not the right thing to do. But not everybody has a medical background is what they will tell you. Um, so in a situation like that, I would say you need to have documentation that spells out kind of, all right, you're going to call Dr. Jones' office, make an appointment. If for some reason they can't see you, then you need to come back to us. And we'll help figure out who you're going to follow up with. And that might be a different, a free clinic or a different doctor's office that takes your insurance or takes workers' comp. Um, in an office setting, such as like an actual office setting, an orthopedic office outpatient setting, there are always discharge instructions, or there should be. And, you just want to tell people what to look out for. And yeah, I mean, if somebody has a trigger finger, there's probably not going to be much that they're going to be looking out for. But if you give them an injection, you want to make sure that they understand if your finger gets swollen, it gets red, it becomes very painful, you're not able to move it, all signs that there might be an infection. You need to explain that, and it needs to be on your instructions that say these are the things and this is what you should do. Either go to the emergency department, you call our office and have those policies and procedures in place, because that's another possible pitfall where that's not in place and people don't know where they're supposed to go if there's a problem. And then I called the office and it went to someone's voicemail that nobody ever listens to. Those are things that I've seen where things get fall through the cracks, and then it always falls back on the provider. It's always going to fall back on the provider.
So I have a question. I mean, why do PAs get sued? What happens? Why do they get sued? And then the flip side of that question is, how do you not get sued? Are there strategies you can employ to keep that from happening?
The list is long why you can get sued, and it generally the biggest things come down to the biggest ones are a misdiagnosis or a delay in diagnosis or a delay in treatment. How to prevent those things from happening? You mentioned before you wanna have your differential diagnosis be broad. You can't just hone in on one thing and, "Yep, that's that. That's it. That's what it is." we're treating you for it and not look at the big picture. You always want to be considering other things. And sometimes it's really obvious that it's something, but you still have to run those things through your mind, even if you're just checking them off quickly, like, nope, 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 nope. And these are the reasons why those aren't the case. And then delays in diagnosis, if something happens, you're in the hospital and you see, someone's post-op in the hospital and they're having some shortness of breath and their stat is dropping a little bit. And, you have to consider a PE and you can't sit on that and say, well, they're overweight and they're post-op and they're tired and their calves are soft. So yeah, we'll just keep an eye on it. I mean, you have to have that constantly in the back of your mind. And then you have to be able to approach it and treat it at an appropriate manner. So not missing diagnosis, and it happens. It just happens. I mean, you can do everything right, and sometimes you still get sued, and it's just trying to mitigate those things, and by keeping a broad diagnosis, differential diagnosis in your head, not delaying diagnosis or treatment. There are some other things that come to mind that are sort of, I guess, things that people might not think about. For instance, incidental findings on X-rays or other imaging. We've all seen that where there's a incidental finding of a nodule in the lung, right? And the radiologist says should be followed up in 6 months. And, most of the times it's nothing. But that's something that needs to be told to the patient, and that's something that they need to follow up on. And it's as long as you've told them, look, this was an incidental finding. It has nothing to do with anything here. There's nothing that we need to do to work it up right now. The recommendation is to have it followed up in 6 months. Then, you know, it's on them. Same thing, they saw some sort of something on your liver that needs to be worked up and they're recommending, you have a CAT scan, or they're recommending, those are things that come up and nobody says anything. And then 6 months down the road, the person ends up having liver mets and they go back and they look at the imaging and they say, oh, well, we saw it here. That was recommended that the person go for further testing. And when you look through the records, nobody mentioned it. The patient had no idea. So those are things that come up even in office settings. And I would personally see that in the office setting. It would come back and nobody would really read the report. And one of the physicians I worked for would go crazy if one of the mid-levels or, APPs missed that and didn't send the patient for further testing because it had come back to one of them in the past. They had missed something on a film that they didn't send the person for. So those are things that people don't think of, I think, but you need to look at the report, and if there's anything on there, even if it has nothing to do with your specialty, but the radiologist is saying that they need to follow up or there's something that's funky, set them up with an appointment to see someone and let them find out if it's okay or not.
Those are great points. Time to treat, misdiagnosis, failure to treat, all those things are legal questions saying basically the same thing you did. I want to throw in a couple of things that are a little bit off from that, but don't talk bad about somebody else's care in front of a patient. Just don't do it. That's bad business for everybody, and that's a lot of reasons why a lot of people get sued. "Oh, I can't believe that Miles did this. He did what? How did he inject it? Oh my, I've never seen that before." That kind of stuff. Don't do that. That's just bad. Just bad, bad, bad. Like you said, your doc kinda, reamed out a PA for missing something. That's one thing, but don't do that stuff in front of a patient. If you wanna talk about the number one reason why people get sued, it's because somebody badmouthed you to another provider and it comes out. And I did a podcast, I think 4 years ago, whatever, with 2 defense attorneys, and they said that's one of the biggest ones. So, keep your opinions to yourself, share them with your colleagues or, regular doc. Don't talk about somebody else's care in front of a patient. It's just not good.
I would also say, do not put that in the chart. I don't
Yeah, definitely.
don't write that in the record, right? When there's an argument going on in the record or people are criticizing other people's care in the record, then it's just fodder for the defense attorney.
Oh, yeah, and, or plaintiff's attorney, they love that stuff, they'll eat it up.
Sorry, plaintiff's attorney, right, that's what I meant.
Yeah. We talked about that, don't badmouth for want of another word. Patients like to be listened to, and even if you think, "Oh, man, what do you mean you don't understand? You're not getting this?" Take the time, listen to them, listen to their story, talk to them about it, get through it. The person that spends about 90 seconds and has their hand on the door and looking at their watch as somebody's giving them their story, something goes wrong, who do you think is gonna get sued? That cat or the person that sat there and talked to them about their dog and their family and their vacation and stuff? You're not gonna get sued if somebody likes you. 99% of the time, that's not gonna happen. In fact, when I had this discussion with some defense attorneys before, that they had a couple of cases that they could remember where there was an obvious malpractice situation, but they said, "Take the PA out of it because, we like him, they've done good for us, and we don't wanna have them involved in this." But the surgeon, on the other hand, boom. So, try to have a good rapport with your patient. It's not like a contentious thing, it's not like us against them or whatever, you're on the same team, and you want them to feel that, and if they feel like they haven't been listened to, and then something comes up that's wrong, you're more likely gonna get sued in that situation, and that's been my experience.
I would agree. It's not 100% guarantee, but you're correct. People are less likely to sue someone they like, but they're also one of the biggest things that even cases, because people come forward with cases, things happen, there's a bad outcome, and they wanna know what happened. And it's not always negligence. I think one of the biggest misconceptions is that all cases go forward, but the truth is for every 100 cases, they're really only getting about maybe 1 or 2 cases out of all of 100 cases that attorneys get presented to them. Most of the cases are not cases. They're not cases they're going forward. They don't have all the components, the standard and causation and damages, those things are not all there, but it doesn't mean something bad didn't happen. And a lot of times people just want answers. There's a lack of communication. It all comes back to communication. There's poor communication. They don't know what happened. Something went wrong and nobody ever explained to them what happened. Nobody ever explained to them before or after. So they're left thinking that something went terribly wrong and it must have been negligence on the part of the provider. So a lot of times people just want answers. They just want to know what happened. And and they're fine with knowing that it's not negligent as long as they can understand what it was and it was explained to them. So, if there's a surgeon who has a complication and they haven't explained they haven't taken the time to explain to them, what could go wrong before the surgery. And then after the surgery, if they just kind of blow them off and they're not really taking things serious and explaining to them what's going on, then that's going to make someone feel like, well, they're not being truthful with me. Something did go right here. If you sit down and you say, okay, these are the risks of the surgery. These are the possible complications, and then after surgery, something happens and they say, this is what went on and this is why this is happening. This is how we're going to manage it. Those people feel less inclined to sue because they're getting the communication. They're understanding. Someone's explaining to them what's happening. So explaining to someone in real time what's going on helps to mitigate down the road trying to explain to them with lawyers present.
You know, we're not trying to make our audience feel like you have to practice in fear. It's not like that. You do a good job and get the diagnosis. But sometimes stuff happens. I won't use the colorful adjective, but stuff happens.
Mm.
Is a mistake always malpractice? The answer is no, it's not. So it just depends. It's kind of deciding what standard of care and what's not. You need to be familiar with that, but that's not something you decide. That's something the attorneys figure out. But yeah, if you're upfront with your patient, spend some time with them, talk to them, know a little something. One thing I did in my charts Like somebody was going to whatever to beach holiday that they hadn't been on in years, put a little one-liner in your note. And so when they come back, you just say, "Hey, how was the vacation? Hey, how was the marriage? Hey, how was the anniversary?" It's like an instant bond. You can almost see them relate to you immediately. Those folks aren't gonna sue me. You know what I'm saying?
Hmm.
You gotta do stuff like that, so it's a person that you're talking to, it's not just a number sitting across from you. I guess that's what I'm
Right.
trying to get to. Susan, we're so excited that you're here today, and thank you for your information.
Well, thank you for having me.
Listeners, please join us next week when we continue our conversation in medical legal consulting with Susan Ferrero. Thank you for joining the orthoPAC podcast. We also welcome you to visit our website, paos.org, where members can download virtual conference content and get Category 1 CME. Also, if you're a non-member and you're interested in our CME content, please visit the aapa.org Learning Central for the PAOS virtual content.